PAX8, PPAR gamma translocation, KRAS, RET mutations, BRAF V600E mutation. Okay, time is up. Your correct answer is your BRAF V600E mutation. So genetic alterations that activate the mitogen activated protein kinase or MAPK pathway are common in papillary thyroid carcinomas. These include point mutations of BRAF and RAS genes. Your BRAF V600E mutation, which is a point mutation of the BRAF gene in which valine is substituted by glutamic acid, in papillary thyroid carcinomas are associated with classical and tall cell histologic appearance and predict more aggressive behavior even in PT1 tumors. They are seen in only 10% of follicular variant tumors. And here's a look at our leaderboard. So looking at the pertinent clinical information, we can start to form differentials. So again, we have an FDG, avid right lung mass on PET scan, and a large peripherally enhancing ovoid density noted on CT scan. The patient has a history of PTC with 9 of 10 lymph nodes positive for metastasis and bronchial washings with atypical cells. Stop to think of the most common differentials given the patient's history alone. With the diagnosis of atypical cells on bronchial washings, the attending physician decided to go forward with lung resection instead of having the immunohistochemical stains done on the bronchial washings. She was subsequently admitted in our institution and underwent single-port video-assisted thoracoscopic surgery with partial lung resection of the right middle lobe. The intraoperative findings described a 2.5 centimeter hypervascular mass at the right lateral segment of the middle lobe and was noted with minimal adhesions to the right upper lobe. The specimen was submitted for frozen section and consisted of a well-circumscribed mass measuring 3.3 by 3.3 by 2.3 centimeters with an attached sliver of lung parenchyma. This is a scanning view of a smear done on frozen section. From low power, we see a papillary-like configuration. We see cells with round, ovoid, vesicular to hyperchromatic nuclei, some with prominent nucleoli and nuclear grooves, irregular nuclear membranes, and ample eosinophilic cytoplasm. And this is just another view of the smear. This is a scanning view of the resection specimen on the permanent slides. We see predominantly papillary growth with minor components of solid growth. Again, the papillary pattern is quite striking. That's a nice nuclear inclusion pointed by the green arrow. We will go through the cell morphology later, but I think you may have good differentials in mind already based on the clinical information and the architecture of the neoplasm. So what are your differential diagnoses at this point? Which IHC stains would you request? So a question is coming your way. What would be a good set of immunohistochemical stains to request in order to differentiate the most likely differentials? So A, TTF1, CK7, CK20 thyroglobulin, B, TTF1, thyroglobulin absent A, PAX8, C, PAX8, thyroglobulin, TTF1, D, TTF1, P40, BER-EP4, calretinin. Time is up. So the correct answer is B, TTF1, thyroglobulin, absent A, and PAX8. This set is good because it will differentiate between a primary pulmonary neoplasm with a metastatic papillary thyroid carcinoma. And this is a look at the leaderboard. So on the permanent sections, we observed a predominantly papillary growth pattern with minor components of solid growth. Our differential should include metastatic papillary thyroid carcinoma versus a primary lung neoplasm. namely a papillary predominant adenocarcinoma given the architecture, morphology, and location. The following stains are requested to help us differentiate among the differentials: TTF1, napsin A, Pax8 thyroglobulin, and P40. So one more question ahead. What percentage of lung adenocarcinomas are of the pure papillary subtype? Less than 1%, 3 to 10, 10 to 18, 15 to 20, or greater than 20. All right, time is up. Correct answer, 3 to 10%. And let's look at the leaderboard. So going back to the case, TTF1, or your thyroid transcription factor 1, is diffusely positive. It is a nuclear marker expressed in thyroid, lung, and brain structures of diencephalic origin. Your Pax8 is a nuclear marker with expression in epithelial neoplasms of thyroid, thymic, ovarian, endometrial, endocervical, fallopian tube, and renal origin. Pax8 shown here is negative. Thyroglobulin is a large glycoprotein produced by thyroid follicular cells and is a specific marker of thyroid differentiation. Thyroglobulin is negative. Napsin A is found primarily in lung and kidney and has a cytoplasmic staining pattern. Napsin A is positive in lung adenocarcinoma versus squamous cell carcinoma, which is negative in tumor cells. It is superior to TTF1 in distinguishing primary lung adenocarcinoma from other carcinomas except the kidney. Napsin A in our specimen is positive, though only focally. Based on the staining pattern of the IHCs, a primary lung neoplasm over a metastatic process is favored. We have a positive TTF1, focally positive napsin A, and a negative Pax8 and thyroglobulin. So let's go back to napsin A. See anything striking? It seems like there are two populations of cells, evidenced by the focal staining of napsin A. The blue arrows point to the surface cells, and the red arrows point to the stromal cells. We should review and go back to the morphology of the tumor. Again, the blue arrow points to the first population of cells, or surface cells, that seemingly line the surface of the papillae and has cells with round to ovoid, vesicular to hyperchromatic, mildly pleomorphic nuclei, occasional prominent nucleoli and nuclear grooves. And we have a nuclear inclusion pointed by the green arrow. Also, there's irregular nuclear membranes and ample eosinophilic cytoplasm. These cells were diffusely positive for napsin A. The red arrow points to the second population of round cells located within the stroma. They have round vesicular nuclei, inconspicuous nucleoli, and ample amphiphilic cytoplasm. The second population was only focally and weakly positive for napsin A. No mitosis was observed in the mass. So at this point, we had a diagnosis in mind, but requested CK, EMA, and CAM 5.2 to strengthen the diagnosis. The surface cells were diffusely positive for CK, and stromal round cells were only focally and weakly positive. The surface cells were diffusely positive for EMA, and stromal round cells were only focally and weakly positive. The surface cells were diffusely positive for CAM 5.2, and the round cells are negative. TTF1 appeared to stain both populations. So in summary, we have a 40-year-old Filipino female with an FDG-avid right lung mass on PET scan. She has a history of papillary thyroid carcinoma with metastasis to the lymph nodes. Bronchial washing showed atypical cells, and a well-circumscribed hypervascular mass was resected from the right lateral segment of the middle lobe. We considered a primary lung neoplasm and noted two populations of cells, surface cuboidal cells and round stromal cells. TTF1 was diffusely positive in both populations. The surface cells were diffusely positive for napsin A, CK, EMA, CAM 5.2. The stromal round cells were focal and weakly positive for napsin A, CK, and EMA, but negative in CAM5.2. Both populations were negative for PAX8 and thyroglobulin. So after reviewing all the pertinent clinical information, morphology, and immunohistochemistry, we have a diagnosis. Let's go to question number 5. What is the diagnosis? So metastatic papillary thyroid carcinoma, pulmonary sclerosing pneumocytoma, lung adenocarcinoma, papillary predominant, mesothelioma, lung adenocarcinoma in situ, or bronchoalveolar adenocarcinoma. All right, time is up. Your correct answer is pulmonary sclerosing pneumocytoma. That's our leaderboard. So overall, given the morphology of the tumor that showed a dual population of cells with distinct immunohistochemical staining patterns, a diagnosis of pulmonary sclerosing pneumocytoma was rendered. There were no postoperative complications and the patient was discharged in stable condition. We also checked for mutations for EGFR exons 18, 19, 20, and 21, which there were none. So stand by for another question. Pulmonary sclerosing pneumocytoma was known as what prior to the 2015 World Health Organization classification of tumors of the lung, pleura, thymus, and heart? Is it histiocytoma, xanthoma, sclerosing hemangioma, or sclerosing pneumocytoma? All right, time is up. Correct answer is sclerosing hemangioma. And our leaderboard. We will now discuss pulmonary sclerosing pneumocytoma. This is a rare benign pulmonary neoplasm with differentiation towards primitive or embryonal respiratory epithelium. The surface cells have resemblance to pneumocytes. It was known in the past as sclerosing hemangioma prior to the WHO 2015 update and renamed to sclerosing pneumocytoma, as the original name is a misnomer, named so because it had a morphologic similarity to the dermatopathology lesion previously called sclerosing hemangioma, now known as dermatofibroma. It is most frequent in middle-aged females, but can affect in all age groups. Molecular alterations include allelic losses at P16 and RB loci on fish, aberrant mTOR signaling, but no alterations were found in EGFR, HER2, and KRAS. Majority of large series reports come from South Asian countries with high incidence of PSP and East Asian populations. Upon research, there were 2 known cases reported in the Philippines. One is from Makati Medical Center, reported in 1997, and Philippine General Hospital in 2018. The majority of cases have no symptoms associated, though 20% have respiratory symptoms at discovery of the tumor, namely dry cough, hemoptysis, chest pain, and shortness of breath. The majority are non-smokers. The lesion is grossly a solitary lung nodule, occasionally multiple or bilateral, and occurs in a peripheral location with a high frequency in the right middle lobe. CT imaging reveals well-circumscribed smooth outlines showing homogeneity. Less dense areas may represent cystic change, and average diameter is 2.2 centimeters. The tumor resected from the patient's right middle lobe corresponded to this description. The tumor was circumscribed, soft to rubbery, with an attached sliver of lung parenchyma. The surgeon noted the mass to be hypervascular intraoperatively. The neoplasm comprises of 2 cell types, the surface cuboidal cells and round stromal cells. These can be seen in 4 patterns, but the papillary arrangement is the most common. The surface cuboidal cells mantle the papillary projections, and some may have pseudo-inclusions. The stromal cells are found in the cores of the papillary structures and form solid sheets. They are polygonal, have oval nuclei, dispersed chromatin, and inconspicuous nucleoli. Some may also have cytoplasmic vacuolization. So many of these nuclear and architectural features overlap with papillary thyroid carcinoma, which the presented case had a history of. The complex branching papillae with fibrovascular cores and nuclear membrane irregularities showing nuclear grooves and nuclear pseudo-inclusions are shared in both tumors. Therefore, careful care is not to dismiss hastily the lesion as metastasis must be taken. Diagnosis can be done by fine needle aspiration, but most are diagnosed via resection. PSP is frequently misdiagnosed as adenocarcinoma in situ, formerly known as bronchoalveolar adenocarcinoma, metastatic papillary thyroid carcinoma, carcinoid tumor, and mesothelioma. Immunohistochemistry is helpful in the diagnosis of PSP, and both cellular components of the tumor show specific reactivity. Below is a summary of the immunoreactivities of stains based on the literature. Both surface and round cells are positive for TTF1, EMA, and vimentin, with expression of ER and PR being variable. Napsin A, AE1, AE3, and CK7 are only positive in the surface cells. In a study by Malecki et al., surface cells were immunoreactive for CK, AE1, AE3, EMA, TTF1, CK7, and Napsin A in 100% of their histologically confirmed PSP cases, and negative for CK20. The round cells showed immunoreactivity for TTF1, EMA, CK56, P63, and SMA in 100% of their PSP cases, with all being negative for AE1 and AE3. Your mesothelial markers such as calretinin, HbME1, and WT1 were absent in other cases. Prognosis is good as the lesion behaves in a benign fashion. Surgical excision with wedge resection is curative, and only rare cases of lymph node metastasis have been reported. Our patient underwent wedge resection of the right middle lobe mass, was discharged in stable condition, and advised follow-up. So in conclusion, the diagnosis can be complicated if the papillary architecture is predominant, mimicking primary pulmonary adenocarcinoma and metastatic papillary thyroid carcinoma. Although this tumor is uncommon, the appearance on radiographs, morphological features, and immunohistochemistry are distinct, and the diagnosis can be accurately made. So get ready for the last two questions. Which of the following statements is false regarding pulmonary sclerosing pneumocytoma? Comprises of two populations, cuboidal stromal cells and round surface cells, frequently misdiagnosed as metastatic papillary thyroid carcinoma, behaves in a benign fashion, most commonly as solitary and peripherally located lung nodule. Okay, time is up. Your correct answer is comprises of two populations because it's round stromal cells and cuboidal surface cells. The rest are true. And our last question, based on the literature, which immunohistochemical stain is expressed strongly on the surface cells only? The EMA, SMA, HbME1, Napsin A, P63. Time is up. Correct answer is your Napsin A. And our leaderboard.
For the first round, we have University of Santo Tomas Hospital with 5,938 points, leading. Our second place is the Medical City Ortigas, 5,375 points. And the third place is Tundom Medical Center with 4,157 points. This is just the beginning. It's still anybody's game. For comments regarding this case, we will call the consultant in charge, our own specialist in thoracic pathology, Dr. Rex Michael C. Santiago.
Hi, good evening, everyone. Is my mic working?
Yes, Doc, we can hear you.
Okay, hi, good evening. First of all, I would like to thank you all for attending tonight's educational exercise. It is truly a wonderful thing to see that this activity has grown over the years. So PSP, as mentioned by Dave, is discussed under the adenomas of the lung in the latest edition of the WHO. He also highlighted how this lesion can be a potential pitfall for many often more aggressive entities. And I guess perhaps the most important thing to remember in considering adenomas is that generally they tend to be well-circumscribed, slow-growing tumors that usually occur in a younger age group. Hence, in these situations, you should always consider this set of differential diagnoses in mind. So this is a really nice instructive case in that it highlights some of the complexities in dealing with lung lesions. Because of how routine lung specimens have become, we may sometimes fall into the trap of limiting our differential diagnosis to lesions that we commonly see or to those situations that we encounter more often in daily practice, which is in particular deciding whether a particular tumor is primary or metastatic to the lung. However, we should always remember that we need a systematic approach to lung lesions in that we should ask ourselves, is the lesion neoplastic or non-neoplastic? If it is neoplastic, is the lesion benign or malignant? Is the lesion primary or metastatic? By asking ourselves these questions, we are able to keep an open mind to the many more possibilities and etiologies of a given lung mass. Thank you all, and please stay for the next two equally interesting presentations coming your way.
Thank you, Dr. Santiago. And now, the question and answer portion. You may now type in your questions. Gentle reminder, everybody, we will only be choosing the first 3 questions. So our first question is from Dr. Emmanuel Garcia. Would we be able to diagnose pulmonary sclerosing pneumocytoma using IHC on a cytology specimen?
Sorry, is the question addressed to me or to Dave? Or anyone?
To you, Dr. Santiago.
Okay, to me. So, so generally, I would have to agree that it's very difficult to diagnose on cytology material alone. So this would probably require a lot of multidisciplinary discussion. So if you see that the lesion is very low grade, and also that with the correlation of imaging, and you see that it's a well-circumscribed tumor, then you may want to kind of step back on your diagnosis of if you want to call it a malignancy, you may want to step back a bit if you see that it's a lower grade lesion, and you see that it's well-circumscribed and slow growing on clinical and imaging studies. But if you want to base it on cytology alone, it's going to be very, very difficult.
Thank you for that answer, Doctor. Any more questions? Okay, since we don't have any more questions, let's proceed. That's it for our first case. Dr. Fintecha and Dr. Santiago, once again, thank you very much. Let's now proceed to our next case, which will be presented to you by our Chief Resident, Dr. Vincent Francis P. Castillo.
Good evening. Lung cancer remains the first leading cause of cancer death in both men and women, with 2018 estimates accounting for 1/5 of all cancer-related deaths in the Philippines. In response to this, huge advances has been made in targetable oncogenic drivers. With this, we have come to a realization that these drugs do not work for every patient. This rapidly led to the need to select patients to ensure a higher chance of therapy response. This is the idea of precision medicine. With this, pathologists have assumed a central role in guiding the care of patients with lung cancer. My objectives for today's CP presentation are to present the case of lung carcinoma harboring an unusual mutation profile and its clinical implication, and also to review the current state of precision medicine in the country. The patient is a 79-year-old Filipino male, never smoker, presented with a pulmonary mass on chest X-ray, which was then confirmed by chest CT scan. This was the case from another institution and was referred to us for an EGFR molecular testing. We receive a slide with its corresponding paraffin black labeled as pulmonary mass. Microscopic sections of the specimen showed an invasive malignant epithelial cells, demonstrating predominantly acinar growth with minor components of papillary and micropapillary patterns. The stroma is hypercellular with some lymphocytic infiltrates. The diagnosis of lung adenocarcinoma was already been established by the referring institution based on the histomorphology as well as the TTF1 positivity. We then reviewed the case and made sure that a diagnosis of lung adenocarcinoma, whether based on morphology alone or in conjunction with immunohistochemical staining profile, before proceeding to molecular testing. After we assessed the morphology and established the diagnosis, we then proceeded with determining the adequacy of the specimen. Is this adequate for molecular testing? You see there are multiple pre-analytic factors that contribute to the adequacy of your particular specimen. And the principal factor is the volume of the tumor that is present in the specimen, including the 2 dimensions present on the slide, as well as the 3rd dimension, how much tissue remains in the paraffin block. The second and often more challenging factor is to consider the percent tumor cellularity. And when determining cellularity, it is important to remember that it is the nuclear content that should be assessed and not merely the area of the slide that the tumor cells are occupying. Inflammatory cells will dilute the immune mutant allele fraction, which could then fall analytic sensitivity present in the molecular testing platform. Necrosis can also alter the quality of the DNA isolated. So what is the minimum cellularity? Well, it depends on the analytic sensitivity of your molecular assay. Because many lung cancer samples are small and comprise a majority of benign stromal cells, the guideline recommends that the analytic methods must be able to detect mutation in a sample with 20% or more malignant cell content. And for this case, considering the hyperstroma infiltrated by lymphocytes and minimal necrosis, the tumor cellularity is approximately 30%. And since our institution utilizes a molecular assay that has 5% limit of detection, we deem this sample adequate for EGFR molecular testing. So for the first question, when testing for EGFR mutations in lung cancer, the following are the recommended assay techniques, except, is it A, IHC, letter B, PCR, or letter C, NGS? So the answer is letter A, immunostain. According to the guideline, it is not appropriate to use immunostain, including the mutant-specific immunostain in selecting anti-EGFR treatment for lung cancer patients, because the targetable mutation has no bearing on the extent of the expression of the cell surface, which is what is detected by the total EGFR immunostain. So 15 nanogram per microliter genomic DNA were isolated, and this was adequate considering the minimum DNA stock concentration of this assay is 2 nanogram per microliter. The target DNA was then amplified. Mutation analysis was performed through real-time PCR analysis using the Cobas 4800 system version 2, wherein the analysis of raw data and reporting of results were fully automated. A mutant control and a negative control were included to confirm the validity of the run. Using the Cobas 4800 analyzer, an exon 21 point mutation L858R was detected. And fortunately, this mutation is associated with sensitivity to first and second generation tyrosine kinase inhibitors. EGFR mutation frequency is about 50% in tumors from Asian patients with adenocarcinoma versus 20% in Caucasian population. And among Filipinos with lung adenocarcinoma, it has been reported that 42.6 or 50% of cases are positive for EGFR mutation. EGFR mutations are frequent in tumors with adenocarcinoma histology, with never smokers or light smokers for tobacco, or in women. So how about the non-adenocarcinoma, non-small cell types? Based on the guideline, it is not recommended to test all small biopsy samples with these types of histology. However, molecular testing is still appropriate to perform when clinical features are atypical and or consistent with a higher likelihood of targetable mutation. Question number 2. So for question number 2, among the EGFR molecular alteration, which is or are regarded as positive predictive biomarker or biomarkers for the response to the first and second generation TKI? Is it A, deletion mutation in exon 19? Letter B, T790M substitution in exon 20? Letter C, C797S substitution in exon 20? Or letter D, B and C? Time's up. And the correct answer is letter A, deletion mutation in exon 19. So the two most common EGFR mutations are L858R mutation in exon 21 and deletion in exon 19. Both of them are regarded as positive predictive biomarkers for response to EGFR TKIs, first and second EGFR TKIs like gefitinib or erlotinib. Exon 20 insertions are considered resistant to EGFR targeted TKI therapy. Most patients who initially respond to EGFR TKIs will eventually require or acquire resistance, and the majority is mediated by the secondary T790M mutation in exon 20, which can be targeted by third generation EGFR therapy, osimertinib. And data are emerging that there is a second acquired resistance mutation, the C797S, that can arise in tumors that have progressed after osimertinib treatment for T790M disease. But these cases are so far rare, and this mutation is poorly studied and not currently treatable. So testing for C797S is not recommended for routine management at this time. We had encountered one case with C797S mutation, although it is detected by NGS assay, since molecular alteration is not included in the Cobas EGFR mutation test version 2. Interestingly, aside from L858R, the T790M mutation was also detected in the same sample. We then repeated the test to confirm the presence of these dual mutations, and the result was still the same. So there are two explanations for this. More commonly, the patient has been treated with first and second generation TKIs, and a subclonal population of the tumor developed T790M mutation. We then contacted the treating oncologist and confirmed that the patient is treatment naive. Therefore, the patient has a de novo T790M mutation along with the L858R mutation, a compound EGFR mutation. De novo EGFR T790M is surprisingly common, and depending on the sensitivity of the detection methods used, the frequency has been reported to be 25 to 65%. It is more commonly associated with L858R mutation than that of the exon 19 deletion, just like our patient. So what is the clinical significance of this de novo T790M mutation in terms of survival progression or survival prognosis, as well as the TKI sensitivity? Well, based on this meta-analysis study, compared to the T790M negative patients, de novo T790M positive patients had significantly shorter total progression-free survival and total overall survival. Additionally, in double mutant T790M L858R, sensitivity to EGFR TKI depends on the percentage of the T790M mutation. And when the T790M mutation in cells reach a certain percentage, the sensitivity to the EGFR TKIs decrease. The presence of this mutation further supports the use of osimertinib upfront. However, it is still unclear whether the patients harboring this mutation will benefit more from osimertinib, although there is an ongoing trial for this. We then performed next-generation sequencing using TrueSight Tumor 15 panel from Illumina. Our objectives were to confirm the presence of dual mutations using a different molecular platform to determine the variant allele frequency and to investigate whether this de novo T790M mutation is a germline variant. The extracted DNA from FFPE was amplified using amplicon-based multiplex PCR approach to generate libraries, and sequencing was performed by MiSeq system. This platform uses sequencing by synthesis, so which uses reversible dye terminators to sequence tens of millions of clusters on the flow cell surface in parallel. After analysis, which includes base calling and sequence alignment to reference genome, variants are then annotated. And for this case, we use the Variant Studio 3 software, which will automatically provide the list of detected variants. The assay identified the T790M mutation at the allele frequency of about 3.9%, which tells us that this is not a germline variant, but rather a subclonal population. However, the L858R mutation was not called. We then reviewed the aligned reads or the BAM file using the Alamut visual software to confirm the result and to look for the L858R mutation, because since we already knew the presence of L858R mutation in this sample as previously detected by the COBAS, the mutation might be filtered out by allele frequency threshold of the assay. You can see in the software the chromosomal map, the reference genome, and the individual reads and their corresponding depth of coverage. So the T790M mutation is located in the exon 20 of the EGFR gene at the position 2369. There is a base change from C to T, which results from a threonine to methionine substitution at the codon 790. And using this software, we also detected the L858R mutation. The L858R mutation is located in the exon 21 at the position 2573. You can see that there is a point mutation from T to G, which results a substitution of leucine from arginine at the position codon 858. No other mutations were detected in this NGS assay. So yeah, it's intense, but it's interesting, right? So enough with EGFR mutation, let's move on to other targetable molecular lung biomarkers. So for question number 3, the following are the must-test molecular biomarkers, as these have proven and approved therapies, except letter A, KRAS point mutation, letter B, ALK rearrangement, letter C, ROS1 rearrangement, or letter D, BRAF V600E. So the most recent iteration of the guidelines stratifies molecular targets in a tiered system, and the must-test group of the genes has proven and approved therapies. This tier includes EGFR, ALK, and ROS1, And the NCCN guideline also includes BRAF in this mandatory group. So the answer here is letter A, KRAS point mutation. So about 5% of lung adenocarcinoma harbor this ALK or anaplastic lymphoma kinase gene rearrangement, with EML4 ALK fusion being the most common rearrangement. The clinical significance of testing this biomarker is that the presence of this translocation predicts the response to crizotinib and alectinib, which are the tyrosine kinase inhibitor. And the guideline recommends immunostain, FISH, and NGS as the assay techniques to detect this biomarker. We use ALK D5F3 to determine the ALK status, which is a recommended equivalent alternative to FISH for ALK testing. This commercially available clone has showed clinically acceptable sensitivities and specificities, ranging from 95% to 100% when compared with ALK FISH results. And for it to be acceptable, you should see a strong granular cytoplasmic staining on the ganglion cell. The assay also uses negative control antibody stained specimen slide. Here is an example of our recent ALK positive case. You can appreciate the homogeneous, strong granular cytoplasmic staining. So to call the case positive, we should be able to see this pattern of staining in tumor cells of any percentage. Another must-test lung biomarker is ROS1 rearrangement, which is observed in 1 to 2% of lung adenocarcinoma. A variety of gene partners has been identified for this rearrangement. And ROS1 translocation positive lung carcinoma have also strong sensitivity to crizotinib and alectinib, just like the ALK rearrangement. So you can use FISH, RT-PCR, and NGS to detect this rearrangement. You could also use ROS1 immunostain as a screening test. However, the positive ROS1 immunostain results should be confirmed with a molecular cytogenetic method. Since ROS1 gene has many established fusion partners, when rearranged, break-apart probe FISH assay is utilized. Each probe binds upstream and downstream to the sequences flanking the known breakpoint region of the ROS1 gene. And in the ROS1 negative FISH analysis, you can see that there are 2 yellow signals, a combination of red and green. In ROS1 positive sample, one of the yellow signals splits, resulting in a separated red or green signals, in addition to the yellow signal from the normal chromosome. We usually evaluate a total of 50 cells, and we need split signals by at least 1 probe diameter in 15% or more of the tumor to call it positive. And since we started our ROS1 FISH assay last November 2018, we detected 3 out of 246 ROS1 positive cases, which is roughly about 1%. Because of the good response of the BRAF V600E mutant lung adenocarcinoma to the brafenib and trametinib therapy, the NCCN recommends testing for the BRAF V600E as well. So let's go to question number 4. The presence of ALK and ROS1 rearrangement indicates sensitivity of lung tumor to crizotinib treatment. What other molecular biomarker predicts the response to this drug? Is it A, ERB2 amplifications, B, MET exon 14 skipping, C, NTRK rearrangement, or is it letter D, RET rearrangement? Time's up. So the second category of molecular targets that are those that should be tested as a part of an extended panel. So this should test targets include MET, RET, ERB2, NTRK, as well as KRAS. And among this, it is the MET exon 14 skipping that can be targeted by crizotinib. So the correct answer is letter B, MET exon 14 skipping. So aside from targetable driver mutation, The field of immunotherapy for non-small cell lung carcinoma has emerged as one of the major therapeutic choices. So what is the role of testing to select patients for treatment with immunomodulatory therapies? So the biomarker selection for immune checkpoint inhibitor drugs that can primarily target the PD-L1, PD-1 axis relies on the assessment of PD-L1 expression via immunostain on tumor cells or tumor infiltrating immune cells. You see, the testing is a little complicated. There are 5 different drugs that are approved or in a late stage clinical trials, and each drug has a paired assay consisting of different antibody clone run on different staining platforms and different clinical cutoff definitions of positivity. Tumor mutational burden is also an emerging biomarker for immunotherapy. However, currently there is no common standard for mutational burden calculation, and you need a powerful NGS sequencer to perform this. In our institution, we are using PD-L1 immunostain 22C3 antibody as an aid in identifying non-small cell lung carcinoma patients for treatment with pembrolizumab. And a 1% or greater tumor proportion score is considered as having PD-L1 expression. To summarize, you can see in this pie chart the molecular landscape of lung adenocarcinoma, and there is still a large piece that is emerging and unknown. Hence, this field will continue to advance. But right now, the identification of driver mutations like EGFR, ALK, ROS1, and BRAF that can be targeted with therapeutic agents has ushered in the era of personalized medicine of lung cancer. The clinical success of these targeted therapies in appropriately selected patients has elevated the role of ancillary molecular testing to standard of care. As such, the role of pathologists has been expanded. We care not only about the precise diagnosis, but also the precise or personalized medicine of the patient. And for the final question, the use of circulating tumor DNA molecular testing is recommended for the following molecular alteration in lung cancer. Is it letter A, EGFR T790M mutation? Letter B, ALK rearrangement? Letter C, ROS1 rearrangement? Or is it letter D, BRAF V600E? Time's up. Now, currently, the use of cell-free plasma DNA as a sample, it is also known as the liquid biopsy, is recommended to detect EGFR exons 18 to 21, including T790M mutation. So the correct answer here is letter A. However, keep in mind that testing for tumor sample is still recommended if plasma result is negative due to its limited sensitivity.
13 questions down, 5 more to go. That was intense. After 2 rounds, we have St. Luke's Medical Center, Quezon City at 3rd place with 7,281 points. The Medical City Ortigas with 7,657 points at 2nd place. And leading the pack is University of Santo Tomas Hospital with a whopping 7,938 points. The scores are tight, but you can still turn the tables.
Good day. To help control
For additional comments, please welcome our molecular pathologist and head of cellular immunology and molecular diagnostics section, Dr. Jose Jasper Alendal.
Thank you for that introduction, Love, and congrats to Francis and the rest of the St. Luke's residents for the successful presentation so far. So over the years, we have seen a growing list of biomarkers that are being required of us to know and to test for. So back in medical school, this is the part of Robbins that we usually skip, simply because it most likely won't come up in the exams. But now, these molecular alterations are not just nice to know, but are part of routine testing and routine part of standard of care for patients. So as pathologists, please be aware of these biomarkers because we are in the best position to guide our clinical colleagues on which tests are to be done on which type of tumor and which subset of patients. On a more technical or practical aspect, I know that most residents are directly handling surgical specimens. No, you must always remember that one of the most important things that affects molecular test results are the pre-analytic factors. How you handle these specimens matters in patients' test results. So things to remember: make sure to fix tissues for 6 to 48 hours. Take small sections that are and pick mostly those sections for molecular testing that are mostly viable, least amount of necrosis, and avoid decalcifying tumor biopsies as much as possible because that basically destroys DNA for using strong acids. For handling small biopsies like fine needle aspiration biopsies, core biopsies, avoid doing unnecessary immunostains. So best practice is to get in touch with your clinician, get the clinical history, get the imaging, and avoid using stains that are not really needed for your workup. And this would avoid using up the tissues that will be needed for these molecular tests, and make sure to conserve these precious samples. Another fact to remember is that not all molecular tests are created equal. So please know the limitations of each of these tests, because again, you will be asked for by your clinical colleagues, by your oncologists, on which tests are needed and which tests are best suited for your patient. So each test has its own sensitivity, specificity, and mutation coverage. So you have to know these technical aspects as well. The last thing to remember is to never stop learning, and there are new things coming up every year, and we owe it to our patients to give them the best possible diagnosis when we read their biopsies or when we sign out their molecular test results. So again, thank you for your time this evening, and I think we have another case coming up.
Thank you, Dr. Andal. Once again, the question and answer portion. You know the drill, doctors. You may send your questions now. We'll only be entertaining the first 3 questions. Okay, we have one question. We have one question directed to Dr. Andal. Dr. Andal, may I know if you have encountered discordances of EGFR mutations with tumor recurrences in lung cancer?
Discordances in terms of results, you mean?
Yes, Doc.
Uh,
Yes, Doc, in terms of results.
There have been rare cases where the mutations may change during the course of treatment, but I don't know if you can consider these as discordances. I do remember some oncologists asking about discrepant results, meaning same sample may have had different results tested across different labs, and that may be due to different limits of detection of each lab, not just the test kit. So each test kit has its own limit of detection, right? It's technical, sort of analytical sensitivity. So if you use the same test kit over 2 different labs, that may even vary because each lab has its own methods of tumor enrichment. So one lab may microdissect or macrodissect the specimens to enrich for that tumor. So one lab may miss a mutation and the other lab that does tumor enrichment may pick up that mutation. So these are some of the more recent instances of sort of discrepant or discordant results. On the other hand, again, these mutations may change over the course of treatment protocols because, again, these targeted treatments sort of give or present a selection bias for different clones of the tumor, so may affect the results of different biopsies taken over the course of the patient's treatment.
Thank you, Dr. Andal. Any more questions? Okay, we have none. A big thank you to our presenter, Dr. Castillo, and Dr. Andal, our reactor. Last, but certainly not least, our final case for tonight will be presented to you by Dr. Rebecca R. Nagdalon.
Okay, good evening, everyone. I hope I still have your attention as we have the last report, which is cystic neoplasm of the neck, a stepwise approach. So we have FC, a 45-year-old male with a 2-year history of left anterolateral neck mass. 2 years prior to consult, patient noted a palpable mass at the left submandibular area. This was not associated with any fever or pain, and no consult was done. Until 1 year prior to consult, the mass continued to enlarge, still without associated pain or fever. A neck ultrasound was requested showing a cystic structure at the left submandibular area, measuring 2.8 by 1.8 by 2.8 centimeters. Subsequent fine needle aspiration biopsy of the mass reported a cyst fluid with benign epithelial cells. Consider a benign lymphoepithelial cyst or salivary gland duct ectasia with chronic inflammation. The patient was lost to follow-up until a few weeks prior to consult. The increasing size of the neck mass prompted him to seek consult again. The past medical history, the family history, and social history of the patient was unremarkable. Physical examination shows a 4 centimeter firm, non-tender movable mass in the left anterior neck. Other findings are unremarkable. A repeat neck ultrasound was performed, showing a large cystic focus with low to high medium level echoes, and is noted in the left anterior neck, measuring 3.5 by 2.7 by 3.2 centimeters. A similar lesion is also seen in the left posterior neck with a measurement of 1.6 by 1.5 by 1.5 centimeters. The thyroid gland was unremarkable. So let's move to our first question. Okay, what is the most common etiology of a cystic neoplasm in the neck in adults? So is it A, infectious, B, a branchial cleft cyst, C, a metastatic carcinoma, or D, lymphoma? Okay, so the most common etiology of a cystic neoplasm in the neck of adults is a metastatic carcinoma. Adult patients who were initially seen with the lateral cystic neck mass must be presumed to have cancer until proven otherwise. Okay. So the patient then underwent excision of the said mass, and we received in formalin a specimen labeled as second branchial cleft cyst, which consists of 2 attached pink ovoid soft tissues measuring 4 by 3.5 by 3.3 centimeters and 2 by 2 by 1.7 centimeters. Serial section shows thick-walled cyst filled with cream tan purulent material. The entire specimen was submitted for examination. Okay. So we see that microscopic sections disclose a thick-walled cyst with sheets of atypical squamous epithelial lining and scattered lymphocytes. Further sections show a lymph node with infiltrating nests of squamous cells. These cells are seen within the lymphoid stroma and appear to line areas of cystic degeneration. Again, these neoplastic squamous cells are seen here beneath the lymph node capsule, forming the solid nests with apparent architectural disarray. On higher magnification, we see the tumor cells here exhibiting cytologic atypia with focal attempts at abrupt keratinization amid smaller, more uniform, non-keratinized squamous cells. Atypical squamous epithelial cells with atypical mitosis are also seen lining the cyst. And necrosis is seen in some areas, and these eventually will give rise to the so-called cyst-like spaces seen on imaging. So the final diagnosis rendered was a metastatic squamous cell carcinoma. So let's get ready for another question. Okay. Which ancillary tests may be utilized to aid in the determination of a primary site? Is it A, P16, B, EBER in situ hybridization, C, HPV in situ hybridization, or D, all of the above? Okay. And the answer is all of the above. These tests may all be used to determine a primary site. Okay. So immunohistochemical staining with P16 was diffusely positive. However, due to the non-keratinizing nature of the squamous cells, EBER in situ hybridization was also performed to rule out a nasopharyngeal origin. Here we see the EBER negative tumor that is strongly and diffusely P16 positive, supporting an nasopharyngeal origin. Multiple directed biopsies of the oropharynx, including diagnostic tonsillectomy, was recommended. Further investigation of the possible primary site of the tumor was done. Flexible endoscopy and thorough head and neck physical examination showed no apparent masses. A PET scan was performed showing hypodense appearance and slight prominence of the lower segment of the left sternocleidomastoid with poorly demarcated hypermetabolic fluid collection anteroinferiorly and stranding densities in the surrounding fat, which may represent post-surgical changes. Also seen is a hypermetabolic left faucial tonsil in comparison to the right. And given the clinical data, this is suspicious for a primary malignancy. The patient then underwent direct microlaryngoscopy as well as diagnostic tonsillectomy and directed biopsies of the uvula, nasopharynx, and base of the tongue. Biopsy of the tongue base showed benign squamous mucosa and minor salivary gland lobules. Nasopharyngeal biopsy showed benign respiratory squamous mucosa and submucosal lymphoid tissue. Villaryngeal mass seen showed squamous mucosa with keratosis but without dysplasia. And excision biopsy of the uvula mass showed squamous papilloma. On the same side as the neck tumor, we see in the left tonsil beneath the tonsillar crypts infiltrating nests of neoplastic squamous cells. These neoplastic squamous cells have non-keratinizing histology. And as in the neck tumors, we see focal areas of abrupt keratinization dispersed in a predominant non-keratinizing histology. Here, we also see the same degree of cytologic atypia as in the neck node. HPV in situ hybridization was done and was positive, supporting the HPV-driven carcinogenesis. So let's proceed to questions. For question number 3. Reflex testing for HPV should be performed in which subset of head and neck carcinomas? Is it A, nasopharyngeal carcinomas, B, oral cavity carcinomas, C, oropharyngeal carcinomas, or D, laryngeal carcinomas? Okay, so reflex testing should be performed in oropharyngeal carcinomas. So in 2017, guidelines regarding HPV testing in head and neck carcinomas were released by the College of American Pathologists. HPV is a major cause of oropharyngeal squamous cell carcinomas, and HPV status has emerged as a prognostic marker that significantly impacts clinical management. Based on their systematic reviews, HPV high-risk testing is recommended for all new oropharyngeal squamous cell carcinoma patients, but not routinely recommended for other head and neck carcinomas. This testing may be performed on the primary tumor or on the regional lymph node metastasis when the clinical findings are consistent with an oropharyngeal primary, as in this case wherein the tumor presented as cystic on imaging and is located at level 2. In a study by Thompson and Hefner in 1998, they reviewed 136 cases of cystic squamous cell carcinomas in the neck. In cases where the primary sites were discovered, 64% of the primaries were in the lingual or facial tonsil, and an additional 8% of cases were in the nasopharyngeal tonsillar tissues. In another study by Goldenberg, Schuba, and Koch in 2006, head and neck cancers predominantly include primary tumors of tonsillar tissue from the Waldeyer strain and are more likely to produce metastases that are cystic and may be erroneously diagnosed as bronchogenic carcinomas. That is, a bronchial cleft cyst that has undergone malignant degeneration. Adult patients who are initially seen with a lateral cystic neck mass must be presumed to have a cancer until proven otherwise. The mass should be biopsied by fine needle aspiration. However, negative FNA findings may be misleading, similar to our patient's case. Therefore, an excisional biopsy and examination under anesthesia with directed biopsies of Waldeyer ring and bilateral tonsillectomy should be considered a part of your diagnostic workup. Okay, for the next question. Which type of squamous cell carcinoma are HPV infections mostly associated with? Is it A, keratinizing squamous cell carcinoma, B, non-keratinizing squamous cell carcinoma, C, basaloid squamous cell carcinoma, or D, none of the above? Okay. So HPV infections are mostly associated with the non-keratinizing squamous cell carcinoma histology. So we have actually one more question coming up after this. And we are happy to announce that since our event has been going well, the first place for the competition will actually receive now 3,000 pesos instead. Okay. The final diagnosis rendered is a squamous cell carcinoma, non-keratinizing. So historically, lateral neck cystic masses were commonly judged to be of bronchial cleft cysts. The proportion of metastatic squamous cell carcinoma in cysts initially presumed to be of bronchial cleft origin has been reported to range from 11 to 21%. In 1881, von Voigtmann first theorized that malignant lesions of the lateral aspect of the neck arise from remnants of the bronchial cleft cyst. bronchial clefts. And at that time, these lesions were labeled as bronchogenic carcinomas, and no attempt was made to search for the primary tumor site. However, with several studies published, it is now thought that bronchial cleft carcinomas either does not occur or is exceedingly rare, and instead, these are cases of cystic metastasis, often from a tonsillar primary squamous cell carcinoma. The appearance of cystic cervical nodal metastasis is a distinctive, specific, and easily recognizable phenomenon that occurs in a subset of HNSCC. It has been recognized that there is a marked predilection for cystic morphology in cervical metastasis to be associated with squamous cell carcinoma of the oropharynx. The phenomenon of cystic metastasis is actually not limited to oropharyngeal primary malignancies, but has also been reported to occur in association with primary cancer of the thyroid, esophagus, and uterine cervix. The phenomenon of cystic nodal metastasis has been postulated to occur secondary to pseudocystic change, resulting from the spontaneous degradation of keratin and cellular debris within the carcinomatous lymph node deposit. However, some may favor that these are actually true cysts lined by neoplastic epithelium in the central portion of the lymph node with lymphoid elements occupying the periphery of the node. HPV-related oropharyngeal squamous cell carcinomas have the predilection for the palatine and lingual tonsillar crypt epithelium, similar to our case where the primary malignancy arises deep within the tonsillar crypts without any gross mass. Normal tonsillar crypt epithelium shows less squamous maturation than surface squamous mucosa and is often infiltrated by your lymphocytes. HPV-related oropharyngeal squamous cell carcinomas have a non-keratinizing appearance, while HPV-unrelated tumors are typically keratinizing. And microscopically, HPV-related non-keratinizing tumors tend to form large nests that have pushing borders with little stromal response, frequent mitosis, and often central comedonecrosis. These cells are ovoid to spindle-shaped with indistinct cell borders and have hyperchromatic nuclei that lack your prominent nucleoli. Squamous maturation is either absent or is limited. So, for our last question, the high level of P16 expression in HPV carcinoma is associated with the degradation of this protein. Is it A, P53, B, MYC, C, RB or retinoblastoma, or D, CDK4? Okay, the correct answer is retinoblastoma or RB.
This was the last round. We will be announcing the final results after the question and answer portion.
Okay. So HPV-related oropharyngeal squamous cell carcinoma is characterized by a transcriptionally active virus with the E6 and E7 transcripts altering cell cycle functions and apoptosis. E6 binds to wild-type tumor suppressor protein P53 through E6-associated protein, and E7 binds to retinoblastoma protein, each leading to their degradation. RB degradation results in an aberrant overexpression of the tumor suppressor protein because RB normally would inhibit P16 transcription. This high level of P16 expression in HPV-related carcinoma is in contrast to conventional head and neck squamous cell carcinomas, where the gene is frequently inactivated by methylation or deletion. And as such, P16 is a very good surrogate marker for HPV-related oropharyngeal squamous cell carcinomas and is easily detected by immunohistochemistry. So there are other ways for testing for high-risk HPV aside from P16 immunohistochemistry. We have PCR for HPV DNA, PCR for HPV E6, E7 mRNA, DNA in situ hybridization, RNA in situ hybridization, other cytology-based techniques, and the use of your combination or algorithms, some of which are available locally. To summarize, in metastatic malignancies, especially those that present as cystic, continued efforts to search for a primary tumor should be exhausted. Thorough history taking, including the sexual history of the patients, as in this case, it was actually retrospectively revealed that he had multiple sexual partners and engaged in oral sex. Physical examination may be misleading as almost all of these lesions appear in the oropharynx as deep submucosal tumors and may be sub-centimeter in size. Pathologists should perform high-risk HPV testing on all patients with newly diagnosed oropharyngeal squamous cell carcinomas, including all histologic subtypes. Thank you.
Let us listen to a few commentaries from our head and neck pathologist. Please welcome Dr. Anne Margaret V. Chang.
Hi.
Hello,
Good
Dr.
evening, everyone.
Good evening.
Can everyone hear me?
We can hear you, Dr.
Okay. Congratulations to the group for such an academically enriching evening. So our case is far from being a rarity, but its value lies in its practical use in day-to-day pathology. And to emphasize that the practice of medicine is multidisciplinary in nature. We pathologists play crucial roles in guiding clinicians in their concomitant management of patients. In this case, the general surgeon had to be convinced that the neck lesion was truly metastatic in nature instead of his benign clinical picture, thus necessitating referral to the ENT service. But the convincing power of a pathologist doesn't stop there, because now you are faced with the difficulty of explaining an oropharyngeal tumor in a seemingly normal endoscopy, thus necessitating multiple directed biopsies of this site and diagnostic tonsillectomy. Remember, patients with HPV-mediated squamous cell carcinoma typically have smaller primary tumors that are often clinically occult compared to their more larger presenting neck metastasis. The need for reflex HPV testing on oropharyngeal carcinomas cannot be fully emphasized, as these HPV-mediated squamous cell carcinomas represent a 30 to 50% reduction in the risk of death compared to non-HPV-mediated carcinomas. I hope this has truly been an enlightening evening for everyone, and good night. I hope you enjoy the rest of your evening.
Thank you, Dr. Chang. You may now ask your questions, doctors. Once again, we will only choose the first 3 questions. Any questions, doctors? We have no questions? Oh, that's a wrap for our presentations. Thank you, Dr. Nagtalan and Dr. Chang. After 18 nerve-wracking questions and 3 thrilling rounds, the results are finally in. But before we announce the results, we have good news, doctors. As announced earlier, the prizes were increased. This is not a drill. The prizes just got bigger. Third place will be receiving a total of 1,500 pesos, while the second place will have 2,000 pesos, and the champion will be winning an amount of 3,000 pesos. But wait, there's more. We will also be rewarding the 4th and 5th placers with 500 pesos each. Okay, on to the announcement. And the winners are At third place, garnering 9,282 points, is the Medical City Ortigas. At second place, with 9,938 points, is University of Santo Tomas Hospital. And tonight's champion, with 11,281 points, is none other than St. Luke's Medical Center, Quezon City. Congratulations, winners. Please expect your GCash prizes within 12 hours. Alas, all good things must come to an end. It seems time really flies so fast when you're having fun. To formally close our program is a prime mover and the founder of the nationwide Consortium for the Advancement of Pathology. Please help me welcome Dr. Rolando A. Lopez. Hello, we have a new, hello, Dr. Jasper.
Yes.
Hello, Doc. We have a new question.
Yes. Go ahead.
Okay, for T790M mutations, which sample is more specific? A plasma sample or an immunohistochemistry on a tissue biopsy on patients with lung adenocarcinoma? Thank you.
So as mentioned earlier by Francis, immunohistochemical staining for EGFR mutations are very limited by their sensitivity and sometimes by their specificity, especially in areas where the pre-analytic factors can affect fixation and processing of the tissues. So if given the choice, molecular testing on tissue would be the first consideration, and if that's not available, a liquid biopsy using plasma is an option.
Thank you, Doc. Thank you very much, Dr. Randall. Okay. Once again, to formally close our program, as the prime mover and founder of the Nationwide Consortium of the Advancement of Pathology, please help me welcome Dr. Rolando A. Lopez.
I'm sorry for that glitch. I got disconnected for a short while. Anyway, one of the bright spots in this pandemic is that we were given an opportunity for the metamorphosis of the MCAP, which was only metro-wide in reach, to NCAP, which is now nationwide. And we also have to thank the PSP for their support in the transition that we made from MCAP to NCAP. For tonight, on behalf of the participants, I wish to thank and congratulate the residents of St. Luke's Global City under the able guidance and supervision of their consultants for their sterling performance in the presentation of their cases. They have been long a member of the MCAP, and I think they waited out till we become an NCAP so that we can have a wider reach for their performance. But certainly it was worth the wait. They were very good tonight, and I'm sure that we will have more performances of this kind from them in the future. On that happy note, I wish to convey the greetings of St. Luke's Medical Center, Global City, to all the participants. May we all have a blessed Christmas and a prosperous COVID-free New Year. Thank you and good night.
Thank you, Dr. Lopez. Ladies and gentlemen, from the bottom of our hearts, thank you very much for joining us tonight. We hope you enjoyed tonight's activity. We will be sending your certificates of attendance to your chief residence email. Please expect them within 24 hours. Should you have any inquiries, please do not hesitate to contact us. Once again, on behalf of St. Luke's Medical Center, Global City Institute of Pathology, this has been your Master of Ceremony. I'm Dr. Loveroy Tehil. Merry Christmas and a Happy New Year. Maligayang Pasko at manigong bagong taon. Feliz Navidad y un prospero año nuevo. Para sa mga bisdak, parehas nako, maayong Pasko o bulahang bagong tuig. Daygunta ang Ginoo. May God bless us all. Good evening. You may send your greetings and well wishes in our chat box, and I'll read them for you. If you have any greetings, please just send them to our chat box. Happy birthday to Dr. Arvin Faundo. May God bless you with more blessings and we wish you more birthdays to come. We would like to extend our heartfelt thank you to our consultants, Dr. Anne Margaret Chan, Dr. Jasper Andal, Dr. Arvin Faundo, Dr. Maria Cristina Briones, Dr. Rex Michael Santiago, Dr. Rolando Lopez, Dr. Rodelia Lim, Dr. Marie Christine Bernardo, Dr. Glendolyn Pua, and Dr. Jake Patag. Thank you very much, doctors. We would also like to thank our sponsor for making this event possible, Dr. Rodelio Lim, Dr. Tina Briones, and Dr. Jasper Andal. Shout out to our pioneer graduates, Doc Mayan, Doc Marian, and my sister from another mother, Doc Cookie. We miss you. To our beloved graduating senior resident, Doc Flora, congratulations, and we are excited for another chapter of your career. Take care in Rhode Island, USA. We are very proud of you. Special greetings to Miss Love Marie Paco Escudero. Sa among silingan diya sa Quezon City, nagpadala po kami ng bag via 8 p.m. shuttle. For hosting bookcase, please contact my manager, Dr. Vincent Francis Castillo, for more details. Thank you for coming. Happy birthday to Doc Paulo Pereira. Happy birthday to Doc Paulo. So it seems like we have a lot of birthday boys today. Happy birthday to Doc Paulo Pereira. And also happy birthday to Doc Faundo. Thank you for coming, Dr. O'Malley.
It's you.
Thank you. From Dr. Celestine Trinidad, Merry Christmas. Merry Christmas to you too, Doc. From Doc Joshua Oibuko, thank you and Merry Christmas. Merry Christmas to you, Doc. From East Avenue, Merry Christmas and Happy New Year. From Dr. Juan Miguel Nelias, my batchmate, thank you. Season's greetings. Kamusta na mo diya sa Cagayan de Oro, guys? Kaya sa mga Bisaya diya, pwede mo magbisaya, kay basahon ako yun.
Natin.